Assalamu alaikum. We will start the long clinical consultation day with Mrs. Julia, 35 years with complaint of cough. Ready?
Okay.
Okay, here we go.
Hello, my name is Dr.
Hello.
Star. I'm one of the doctors here in the clinic today. Can I confirm you are Mrs. Julia, 35 years old?
Yes, I am.
Yes. Just we are meeting here today to discuss your referral letter. It shows that you have some problem regarding having cough. Can you tell me more about that?
Yeah, doctor. Actually, this cough since long time with me and it's on and off. It never goes, doctor. It comes and goes. Whenever I think it's already goes, again it comes back. I don't know why, doctor.
Okay. I'm sorry to hear that, and we are here to help you. Can you tell me since when did this cough start?
Maybe it's since 2 years now, doctor.
Okay, and it has been going on for the past 2 years.
Yes.
Okay. Uh, and it comes and goes, right? It comes in
Yes.
attacks.
Yeah, you can say that.
And between these attacks, you are completely free of any any.
Yes. Yeah, doctor. You can say that too.
Okay. Um, can you tell me if you have seen any physician or any doctor regarding this problem?
Yes, doctor. I went to my GP and he gave me some inhalers and I'm using it, but still it didn't help, doctor.
Okay. So can you tell me what do you think seems to make this cough worse?
He told me it's like asthma
Okay.
and I think, yeah, it's related to certain weathers,
Okay.
pollens, and he told me about these things. But still, doctor, I'm not well controlled.
Okay. Do you have any like pets at home?
And it's not at home, doctor, directly. It's in the garden.
Okay. You live in like a rural area?
No, doctor.
Okay. And you don't have pets at home, right? You don't have pets
It
at
it
home or any
it
birds at home.
I had a cat, doctor. Then my GP told me it might be related. So I put it out in the garden. But
Okay.
again, it's not resolving too much, doctor. Still, I have the symptoms.
Okay. Does this cough come when you are can I ask what's your job? Do you feel that this cough become worse at your job?
I'm teacher, doctor. Not really, doctor. I can't say that, but maybe when I go out, but it's not particularly with the job.
Okay. So it does not improve in the weekends or anything.
No, it's always with me. When I have the attack, it's still with me.
Have you changed in your house in the past 2 years?
No,
Okay. Does it become worse specific time of the day, like in the mornings, in the evening times?
no, doctor.
Okay. Have you got any like difficulty breathing also?
Difficulty, yes. When I have the attack, I feel short, doctor. Short of breath.
Okay. Only during this attack of cough, right? It's not related to
Hmm.
exercise or
No.
does it come when you are asleep at night, when you are flat on the
Yeah,
bed?
doctor. Sometimes I wake up coughing, Then I feel the noise. The noise breathing, doctor. Yes, it happens.
How many pillows are you sleeping now? How many pillows are you using?
One pillow, doctor.
Okay. Um, this cuff has any like phlegm with it?
No, no, doctor. It's always dry.
Okay. Any blood with it? Any blood with it?
No, doctor. I didn't see blood.
Okay. Any chest pain?
No,
Any like racing heart? Like if your heart is racing?
no,
Any like pain in your nose or your sinuses?
no,
Uh, Sorry to ask you. Well, how about your urine? There's any like froth in the urine?
no,
Any like swelling?
no,
Okay. Can I ask you if you have any fever?
no,
Di-
doctor.
Any weight changes?
No,
Any like weather preferences?
no,
Any lumps or bumps in your body?
no.
Any joint pain?
Yeah, doctor. Sometimes I have a joint pain
Can you tell me where is your joint pain?
in my hands, doctor.
Okay. Um, can you tell me since when did this hand pain start?
Actually, doctor, it's since maybe 3 years now. I feel this joint pain.
Okay, I'm sorry to hear that. Have you got any like physician opinion also about this one?
I think he told me some joint disease. I cannot recall the name.
Have you been taking any medication for this joint pain?
Yeah, doctor, he gave me medication called, I think, methotrexate or something like that.
Okay. And it has been helping your joint pain, this medication?
Actually, doctor, it's not that much extent, but still, I'm coping with that.
Okay. So can you tell me um you never had any trauma before this joint pain, right?
No,
Okay. And can you tell me the severity of this pain? Like scale of 1 to 10?
it's like 4 to 5.
Does it come in يعني like you does it sorry does it improve with like exercise or with rest?
Yes, doctor, you're right. It improve when I do exercise. When I have rest, it worse.
Okay, I'm sorry to hear that. Does it have you have any stiffness in this like hands or the
Yes,
joints?
doctor, you're right. Yes.
Does it do I know sorry, can I ask how long this stiffness will stay?
Yeah, when I wake up, doctor, almost 1 hour.
Okay. Uh all right. Can you tell me also if you have any other joint pain other than your hands?
No, doctor, only the hands.
Okay, any back pain?
No, doctor.
Any skin changes or skin rash?
No,
Any hair changes?
no,
Any eye changes?
no,
Any muscle weakness or muscle pain?
no, doctor.
Any bowel changes?
No,
Any other urinary changes? May I ask about the froths? Any other urinary changes you have?
no, doctor.
Uh, okay. Can I ask you if you had any other past history, like past health problems other than this hand pain and the problem with the
No,
breathing?
no, no. Only
Are
that.
any surgical, like any surgeries you had before?
No,
Any allergies?
no.
Are you smoking?
I was, doctor, but I quit.
Okay. Are you drinking alcohol?
Socially, doctor.
Okay. Um, can I ask, sorry, can I ask you some private questions?
Hmm.
Can I ask, um, are you married or you are in a relationship? This is Julia.
Yeah, I have partner, doctor.
Okay. Uh, can I ask about your period? Is it regular?
Yeah, doctor, no change.
Okay. When was your last period?
3 weeks back.
Okay. Have you ever got pregnancy or you got pregnant?
No, doctor, still. I'm planning.
And no abortions, right? Sorry to ask you. No abortions you had.
No miscarriage, doctor.
Um, okay. Can I examine you?
Sure. What you want to examine?
Uh, okay. First of all, I want to examine um because she come with the chest problem. I would like to start with the chest. I
Okay.
would like first to have to see the chest expansion.
Chest expansion. Okay. Normal.
All right.
No reduction.
And respiratory rate is okay, right?
Uh,
Respiratory,
the respiratory rate or what? What in the
yeah.
respiratory?
Respiratory rate is how much is the respiratory rate?
No, she's not tachypnic now.
Okay.
20.
Uh, any scars or any problem with the
No,
any inspection? Uh, percussion, any changes?
no.
Okay. Can I auscultate also the back?
Yes, you have scattered wheezes all over.
Uh, okay. Over the back and over the front, right?
Yes.
Um, okay. Can I examine the hands? Can I examine first? Can I do inspection of the nails?
No change in the nails.
Okay. Can I examine the joints? Inspection of the joint, any deformity or any scars?
No, it's no scars, no signs of inflammation, no tenderness, no effusion,
And no deformity also, right?
no deformity.
Okay. Can I check the move? And there's no effusion, right? No joint effusion?
No effusions.
Okay. Can I check the movement? Prayer and reverse prayer.
Yes, functional wise, she's okay. She can do reverse prayer and prayer sign.
Okay. Can I check about the tunnel test?
Yes, negative, no carpal tunnel.
Okay. Um,
What else?
mm,
Okay, 2 minutes remaining. Two
mm,
minutes.
okay. Um, Yeah. I think, Mrs. Julia, that after examining you and thinking history, I think that you have uh, in your hands what we call rheumatoid arthritis. It's like, so don't mind the medical name. It's like your defense system is attacking your joints and causing this pain. And um, with this rheumatoid arthritis, there could be also associated some disease in the chest, in your chest, that has caused this recurrent cough and also the recurrent difficulty breathing. Any other concerns, Miss Julia? I said I didn't
Yes,
ask.
doctor.
Uh,
Yeah, you didn't. You assume my concern, doctor. It's okay, but I'm not concerned about my hands.
uh,
Uh, yeah, I concerned about my chest and the recurrent cough and not improving, wheezy. Why,
uh,
doctor?
Yeah. Also, this defense system that has affected your hands is also has affected your chest, and it has led to this recurrent cough and recurrent problem in the breathing. Um,
Okay, doctor.
and okay, any other concerns, Mrs. Julia?
Yeah, doctor, will you admit me?
Um, I'm not sure. I think that
Okay,
okay.
okay. If you ask the vitals, you will know.
Okay.
Respiratory
Fair
rate,
enough.
okay. Blood pressure, temperature, pulse, everything was okay. Okay, time is up.
Okay.
And yeah, so do you think need admission? The first question.
Um, because the vital signs is okay and the respiratory rate is okay.
Yes, exactly.
Yeah, yeah, she does not seem distressed,
Mm-hmm. Yes, okay.
so I don't think there is need for admission. Yes.
Okay, present for me the case.
What I think the patient has, um, she, يعني,
Present
يعني,
the case. No, no, give me the positive
okay,
history
all right,
finding and examination finding. I didn't ask you what the diagnosis.
all right, okay. On examination of this patient and taking history, I think this patient has rheumatoid arthritis, complicated with it some obstructive lung disease. Um, I cannot remember the
The term.
bronchiolitis. Bronchiolitis,
Yeah.
like
Bronchiolitis obliterans.
upper cancer, bronchiolitis of upper.
Per Perfect. Okay.
Uh,
So you think this is the top of the friendship, but you didn't also summarize the case. Give me summary for the finding and the history.
okay. So this patient has recurrent. Sorry, she has attacks of cough and shortness of breath with no obvious triggers. When we asked about all the triggers of asthma, most of the triggers of asthma were negative, and also other associated um, chest symptoms and cardiac symptoms are negative. And on taking also more history, she had positive joint pain with morning stiffness, and the stiffness stayed for almost 1 hour, which could be due to rheumatoid arthritis. Um, so uh, on yeah, يعني
Yeah,
on
on
examination,
examination, on examination.
I know everything was negative, but يعني in early
You
in
are writing in paper, Dr. Sarah. You are writing in paper, right?
yes, yes,
Yes, you are writing the positive or making circle on the positive
yes,
finding.
yes.
Try to do this because yeah, we are not computer. You cannot remember what you collected positive. So
Uh,
if you didn't write, you will not remember.
uh,
Okay. So
and
in the examination, yeah, let's say in the examination you found what? Positive.
on examination of the chest, we found that there is catheterizes
Hmm.
and um,
Is it
uh,
inspiratory, expiratory? Did you ask?
no.
Okay. Did you ask about the crackles? The crackles?
I assumed that there is no crackles. I did not ask.
Okay. Good as you. Okay. But
Yeah.
you should ask why? Because you might have also interstitial pulmonary fibrosis, right?
Yeah, that's right. It is
Or
still
interstitial lung disease, yes, as a fibrosis, as
yes.
association as well. Okay. The hand, you examine the hand and nothing in the hand. Okay. Let's
But
assume
it,
the rheumatoid is controlled.
yeah,
You didn't
controlled
give me,
early in
yes.
rheumatoid. It can, even with the medication, it's controlled, and early
Mhm.
sometimes the effusion would be minimal, and it couldn't be
Okay.
elicited.
You didn't give me positive drug history, which is or which are.
Uh,
Now you
ah,
remember the defect. Okay.
I,
What's the defect?
I, I didn't I did not ask the drug history.
The methotrexate. I told you the methotrexate. You didn't ask about the dose and
Yes,
the
and
compliance.
yes, yes, that's
And
right.
the inhaler itself, you didn't ask me what is the name
About
and the
the
color.
yes,
Yeah, okay.
Okay.
Leave this point, we will be comment on. The next point, the differential. Yes, give me three differential for this case.
Um. So يعني it could be
You said
yeah
it. Yes, you said it. Bronchiolitis obliterans. Okay, on the
brokerage
top.
of
The next.
uh يعني could be uh bronchial asthma but
Yes, of
يعني
course. Why not?
bronchial asthma.
You should put it. She is
Yes.
already diagnosed asthma and she's not controlled. Whatever the
Yes.
reason, why
Yes.
not
Yes. Correct.
controlled? This is
Uh,
another issue. So we will search and we will try to find out why she's not controlled. But it's the differential number two.
not
Number
number
three,
two.
which you didn't
Uh,
ask,
interstitial lung disease, associated interstitial lung disease with the rheumatoid arthritis.
but
Uh,
it's not. Yeah, as a cough, yes, yes, you're right. Okay,
uh,
as a cough. But if I told you wheezy chest, you can put another differential, which is with asthma.
cardiac asthma يعني.
Oh, GERD. Let's say
Okay.
GERD. Okay.
Jared. Okay. Okay. So
GERD can be as a wheezy chest or asthma exacerbation. Even the
yes.
cough can happen with the GERD. So still the GERD one of the differential. Okay. Let's go now to the investigation.
So first of all, apart from the basic investigations,
Mm-hmm.
we will do CBC, kidney function test, liver function test. Because she had this chest problem, we will do chest X-ray, uh,
Excellent.
to- and
Important.
we may need high resolution and pulmonary function test to
Okay.
diagnose
And arterial blood gas, do you
arterial
think?
blood gas, yes, arterial blood gas.
Okay.
And then
In the CBC, what you will search and what you screen for in the CBC?
uh, because because she's taking methotrexate, we have to
Okay, as a
check
complication, okay, I accept this, but specifically for the asthma, what you will search?
eosinophils,
Yes,
uh,
exactly. Eosinophils and IgE.
IgE,
Okay,
yes, eosinophils and
yes.
IgE.
CRP, of course, you should roll
CRP,
and
yes,
you should screen for infection.
and ESR, yes,
CRP, inflammatory markers, yes, yes. Also for the
and
rheumatoid screening, you should
for
mention, yes.
yes,
The inflammatory markers and the
inflammatory,
antibodies for rheumatoid.
yes, that's right.
Okay, then the pulmonary function, what's your expectation, the pulmonary function test?
Because on the examination we had wheezes, so I'm expecting obstructive. Now she has wheezes, so most probably she will
Obstructive
have
pattern.
obstructive pattern. Yes.
Yes, in
Uh,
the form of,
Forced expiratory volume 1 over the forced vital capacity is less than 70%.
yes,
And
exactly.
if she does not have أنا ما سألتش على التراكية فما أقدرش أقول.
What do you think about the transfer factor in this patient? Might
ثواني
be affected. Okay, when
آه
it will be affected, if there is,
آه آه اللي هي يعني
if there
ترانسفير
is
فاكتور
fibrosis,
فايبروز
if there
لو
is
فايبروز
fibrosis.
هيبقى أيوه صح.
Yeah,
لو
okay.
فايبروز هيبقى affected أيوه صح.
Yes, impaired. Okay, then how to manage this patient? Give me full
So
management plan.
okay. So first of all, we will give her non-pharmacological management. We will refer her to multidisciplinary team formed of rheumatological doctor, pulmonology doctor, occupational health physician, and physiotherapy. Will give her education and counseling, um, and um, then the pharmacological. We will give her management as an asthma for the chest condition.
Okay.
And we will check about the steps بقى اللي هي يعني I'm not sure بصراحة
Stepwise approach. It's okay.
step-wise approach
Okay, another point. Who's the team concerned in this
اه
patient?
the chest physiotherapy uh,
Excellent.
assisted therapy. They will check how she can use the inhalers and
Yes.
teach her how to use the inhalers, and they
Specialized
can
nurse,
specialize
along with
nurse.
the specialized nurse. Okay.
Yes,
Another point important here,
and
uh, in the management. Yeah,
rheumatoid
you
arthritis.
control of the rheumatoid, of
Yes,
course. So the team will be involving the rheumatologist.
yes.
Okay.
The pulmonologist also, and
Yes, of course.
mm, and mm,
Okay.
yeah, physiotherapy and
Exposure. Yes, it's very important. The education, the exposure.
about exposure. Anyway,
Yeah. Do you think still the cat one of the triggers, even she is away?
she's still dealing.
Yeah.
يعني
So you should ask, are
أيوة
you in contact with her or with it?
yes
Are you feeding it?
أيوة
So if still in contact, yes, we should give her some education and counseling. It might be the trigger of her asthma.
yes that's right.
Yeah. Okay. Let's talk specifically about asthma control in her condition, starting by the pet. Already we advised for the pet.
Yes,
Next, the inhaler, the
and
way
here
she's using exactly, we should counsel and we should involve the educational, the specialized nurse how to educate and how she's using.
mm,
The compliance, of course, will be together with the inhaler technique.
mm,
Then about the rheumatoid, yes, we should control the rheumatoid as a complication. And the last point, if we suspect GERD and if there is a positive history of feeling taste in the mouth or acid taste, so I should control that as well by educating about her diet. If she take a diet, should be balanced diet and healthy diet, not spicy because the spicy will increase the acidity. She should sit upright after the meal, and if need, we can give her PPI for 1 month to control the germs. And we consider gastroenterology to do endoscopy if we suspect the GERD. So the GERD is still one of the triggers possibility. I will repeat the differential now. Someone asked about. So starting by asthma itself, uncontrolled asthma for any reason. One of them, the exposure to the pet, pollen's exposure while going outside, or failure of medication or failure of inhaler. If she is compliant to the inhaler, we can consider what's called IgE asthma, and we could consider in this type the monoclonal biological therapy, omalizumab, right? Omalizumab. This is for the IgE asthma. If we suspected and after ruling out all the other triggers. Okay, the occupational, I think, rolled out. So back to the differential bronchial asthma, bronchitis obliterans, since she has the rheumatoid arthritis, and GERD, and interstitial lung disease as a complication also for rheumatoid arthritis. These are the four differential in our case. So back to the comment, Dr. Sarah, well done.
thank you
I think
doctor.
yes, you did the case so great. Apart from some points you missed, I will try to shortly explain. The I think onset course duration, you finish all this thing, what increase, what decrease, and directly to you went. I like when you ask question how the asthma is not controlled, starting by the pet exposure, the job, the housing and painting, any exposure to a reconstruction, then but you miss only the GERD. So put GERD in your mind always because it might be the trigger for hair asthma. The question also for rural life to roll out ABBA, right? And you can also ask exposure to any bird. This is for ABBA as exposure to the bird. Okay, then you ask for the constitutional symptoms to rule out any serious infection. The GI, you ask, but you didn't ask about the acid taste feeling in your mouth. The genitourinary, the joint pain, you screen for rheumatoid. Then the stiffness, very important question you should ask about the stiffness. I waited for this question, although you asked, but later. When you have joint pain, ask about the stiffness if you suspect any inflammatory disease. Stiffness more than 30 minutes, going with the rheumatoid, less than 30 minutes, other or seronegative arthritis. The female history, you ask, yes, you missed the family history again. I don't know why always you miss the family history. It's very important, this patient. You will have some clues in the family history, like rheumatoid in her mother, asthma also. So it's important to ask about. The medical history, you ask all questions for medical, surgical, allergy, and no, I think you didn't ask about allergy, but you didn't ask about the compliance to the methotrexate, any added doses, any other dose, any over-counter medication. It's so important because some patient will take non-steroidal for the joint pain. The inhaler, you should ask also about the technique, how you are using the technique. Are you doing the technique as educated before? Are you compliant? Did you remove? You should ask about how she is compliant to his inhaler, to her inhalers. Sometimes the inhaler itself, compliance or adherence, may be the reason of hair triggers. The examination, you started by the chest. I agree, it's okay, but don't forget the vitals and general look. That's why start systemic. I know this is the complaint, but you might lose the case if you didn't examine for rheumatoid. Since we are starting from the hand going up to the chest, you will not miss the hand. But when you start by the chest, you might forget the hand and you might lose the rheumatoid features if she has. But in this patient, she hasn't. So it's okay in this patient to start with the chest, then the hand, if you will not forget. But please don't forget the associated disease like rheumatoid in our patient. The gel also, again, no question, no examination for the gel, but it will be a history question. I think we cover all for the asthma control management and investigation. I think we investigated all IgE and eosinophilia, plus other inflammatory markers, antibodies for rheumatoid. You can add only ECG and echo for the pulmonary hypertension if she has complicated pulmonary hypertension. High resolution CT chest, pulmonary function test. I think we mentioned all but blood gases and transfer factor. That's it for the management. Multidisciplinary team on the top. The initial thing to mention, multidisciplinary, because we have multi-system affection, so the rheumatoid itself, the heart, the chest, and the immunology. Very important to mention multidisciplinary team in this patient. Start asthma control as stepwise. What inhaler she's on, and this is what you miss. It might be one inhaler. If she's compliant, we would add another, which is inhaled corticosteroid. If already she is on two, we will add another, which is LABA. If she started on SABA, then inhaled corticosteroid, then long-acting beta agonist. You can consider also montelukast. And according to the guidelines, stepwise management approach. In the asthma attack, you should mention if the patient presents an acute attack, we should start with ABCD approach, breathing, circulation, and we might consider back-to-back nebulizer along with steroid injection, along with magnesium sulfate within 20 minutes. This is for the pharmacological management, plus, of course, the control of comorbidity, which is rheumatoid arthritis. I think this is our case today. We cover most of the topic. Any question or any comment? Yes, let's read that. Dr. Hadil asked for Shark, Strauss, or she put as differential. But what you could find, Dr. Hadil, if we suspect eosinophilic granulomatosis with polyangiitis? apart from asthma finding. Okay, Dr. Hadi, I think
She said the patient has hemoptysis, I think.
hemolysis,
Hemoptysis.
hemoptysis, or
Is
kidney
it
affection.
positive or negative? I asked in history of this patient.
No, no,
His
it was she didn't ask, but she asked me about the cough. It was dry, but yes, supposed to ask if she's coughing up blood. It's very important. And the kidney affection, it will be
yes,
frothiness in the
yes.
urine. Yes, it's one of the differential. I
Yes,
agree, but
I collected all disease in one disease, in one phenomena.
yes, yes.
With the chest and rheumatoid arthritis and the autoimmune phenomena.
Association, yeah,
Yes,
vasculitis as a,
yes,
okay, okay, but it will be affecting the kidney, so you might have
yes,
kidney
yes.
affection, frothiness in the urine,
Kind
yes.
of
Plus
spontaneous
hematuria or yeah, hemoptysis,
nephrine impairment.
but no upper airway
Yes,
affection, yes. Okay. Sinusitis also there can be there,
yes.
but it's not in the case. Okay. Could you please repeat the thank you, Dr. Hadid. Thank you. Could you please repeat the differential? I missed it. Okay. Again, the bronchial asthma, bronchiolitis obliterans, then GERD, that's esophageal reflux disease, and finally interstitial lung disease as a complication also to the rheumatoid. Okay. Any question before moving to the next case? Dr. Sarah, write the scenario, please.
Okay.
Okay, male or female? 55 years old, skinnish. Male, so Mr. Donald. Okay, Dr. Sarah, let's start.
Okay.
Okay, hello there. I'm Dr. Mukhtar, the doctor in the clinic today. You must be Mr. Donald.
Yes, doctor. I am the one.
You are 55 years.
Yes.
Okay, we are here to discuss about your health issue. That's okay for you.
Yes, that's okay, doctor. Please.
Okay, can you tell me more about your problem?
Yes, doctor. It seems like there is this rash that's getting really all over my body.
I'm so sorry to hear about that. When it started or when you noticed it?
Um, so I have noticed this one like about one month ago. It's coming all over, like really, it's got all over my body.
Okay, does it appear and disappear or the same since it started?
It's always there, doctor. Yes,
Do you think it's worsening?
yes, doctor. I think it's worsening. Yes.
Okay, where exactly the distribution? I mean, in the face, in the hand, in the tummy.
Yeah, it's all over my back, doctor, over my legs also, and over my arms.
Okay, does it ooze?
No, but when really I scratch it, really, just like a small amount of bleeding come.
Is it itchy?
No,
Okay, you feel over it, the skin over it. Is it painful, I mean?
uh, it's not painful, yeah, but there is some scales over it.
Skin, okay. Can I have a look to your rash? You have any photo or just description? It's okay if you don't have.
I have a photo, but I'm not sure how to share.
Okay, you can send to the group if you have. If no, go ahead.
No, I
Okay,
have.
send it to the WhatsApp group.
Uh,
Okay, Mr. Donald, and do you think something trigger for this rash?
uh, um, no, doctor, I have nothing in mind now that seems to cause this one.
Whenever you have trauma, do you think the trauma followed by the rash?
Uh, yes, sometimes when I got like when like yani, maybe 2 or 3 months ago, when I got some like skin lesion with the knife, I cut my skin with the knife. Yeah, there is some lesion appeared there.
Okay. When you try to remove it, you said it's oozing or bleeding, right?
Yes, that's right. When I'm trying to remove these scales, really, it's really the shape is so bad, so some blood will come.
Okay, is it affecting your mouth?
No,
Sorry for this question. Is it on your private area?
no,
Okay. Is it in your sole of of the feet down?
and not on the sole. It's on the ankles, doctor.
You have any recent infection?
No,
You have any high body temperature?
no,
Any night sweat?
no,
Any lumps or bumps?
no,
Okay. Any change of the weight?
no.
Appetite? How's your appetite?
Yeah, it's okay, doctor.
Okay. You have any long-lasting disease I should be aware of?
Um, yes, doctor. Actually, they told me that I have something called psoriasis. I think this was appearing only on my hands before, but that time I really they gave me some creams and it was better. This was about like 1 year ago. But
Okay.
then, as I told you, this 1 month ago, really this new rash appeared all over my body.
Okay. You have any nail change?
Uh, yes, doctor. It seems like somebody put some needles in it.
Okay. And they also appear in the same duration.
Yeah, it has been for 1 year. 1 year ago, it appeared
Okay.
with this rash on my hands. Yes,
Any joint pain?
yes, doctor. Actually, my hands
ما
is very
البيجامات بتاعتهم هي احنا لبستهم جديد ليه؟
Okay. Is it with the stiffness? Do you notice that there is a stiffness?
Yes, doctor, there is some stiffness in it.
For how long this stiffness you notice in the morning?
Um, I think few minutes, then it will go.
Okay. Apart from this, you have any headache,
No,
any vision problem,
no,
any eye change, color,
no, no.
any redness, I mean. Okay. In your head, you notice this rash behind your ears.
Yes, doctor, yes.
Okay, the same.
Yes, yes.
Okay. Apart from this, you have any weakness in your arms,
No,
any pins and needles.
no,
Okay, any difficulty swallowing,
no,
any intolerance to any weather.
no,
Okay, any chest pain,
no,
any awareness of your heartbeats.
no,
Okay, any change of your bowel habit,
no,
any change of the water work.
no.
Okay, any family history, same problem.
Um, I'm not sure. I think my uncle had some problem also like that. He said that he had some psoriasis.
Okay, and he has any complication with this psoriasis.
Um, no, I don't think so.
Okay, uh, any travel recently,
No.
any medication you are on regularly.
No, I'm not in any regular medication, doctor. No.
So
Except as
no
I told
one,
you, this 1 year ago, they just gave me these creams, but then I stopped it.
did you take medication called steroid, methotrexate?
Uh, no, doctor.
Okay. Any allergy to any medication?
No.
Any over-counter medication?
I'm not taking any medication, but because يعني, I had some problems at work, so they give me some medication because I had really problems. يعني, I had a lot of anxiety and this one, so I think one of my friends gave me one of the medications. I'm not sure about the name.
And I know the name, you don't remember?
Um, I don't remember, but it really has because I had, as I told you, some problems with my work. So they give me this medication. Uh, I think it's called propranolol. I'm
Yeah,
not sure, doctor.
yes, okay. Let me tell you that the taking any medication without medical advice might worsen your condition. So I can ask you to stop this medication till we have diagnosis for your condition. Is that okay?
Yes, okay.
Okay. And do you smoke?
No, doctor, no.
Do you drink alcohol?
Only socially.
How many units?
Maybe around 10 units and the weekends.
Okay. Yeah. The alcohol itself might worsen the condition. So again, I can tell you to moderate and try to reduce the intake. Is that
Okay.
okay?
Yes, okay,
What's
doctor.
your job?
Uh, I am I'm working like a swimming instructor.
Okay, do you notice something impacting in your job because of your condition?
No, but as I told you, 1 month ago I had a problem. They were going to um really get letting me go. So also with this new rash, it's really embarrassing me, doctor.
I'm so sorry for that. So, do you notice the sun worse in this rash?
No,
Okay. May I examine you?
yes, please.
Okay, so a general look how the patient body mass index.
Yeah, it's okay.
She's not, he's not underweight or overweight. Okay.
Mm.
Then now I will examine for the vital,
Normal.
normal vitals.
Mm.
Okay. The hand and the nail.
The nail, there is beating, positive, and
Okay.
distal interphalangeal joint, there is some swelling and some effusion, and
Yes,
also
I will examine the finger. Yes. Okay. Now I will examine the rash in the elbow or the flexor or the extensor.
uh, it's more on the extensor surface and on the back, external surface of the arms and the legs, and also the ankles and on the
Okay.
back.
Let me examine it. It's scaly one, shiny.
Scary
When
and
I,
red.
yeah, when I scratch it, bleed, I will ask them first. Can I do that?
It's not allowed.
Okay. You have pain on it.
No, no pain.
No pain at all. Okay. Any lymph node in the axillary?
No,
Any discharge from this nose, from this rash?
no discharge. No, now no discharge.
In the face, any pallor jaundice? Quick examination.
No.
Any GPP? Any rash back to the ears, behind the ears?
Yes, positive. Yes,
Positive. Any scalp lesion?
yes, positive.
Okay.
On the hairlines.
Hairlines. Okay. Any change or any back pain?
Yes,
I should
positive.
examine. Positive. Sacroiliitis, you mean?
Uh, no, but there is only back pain. Um,
Okay.
but there is yeah.
I can
Good
ask
back.
for the modified sugar and all movement,
Yes.
any
Modif
association of ankylosing, I mean.
Yes. There is positive limitation of movement and modified sugar is positive. Yes.
Okay. Now I'll offer for examining the genitalia, sorry for permission, after permission, of course, the examiner and the patient can
No need.
examine no need. Any, the groin lymph node as well, no
No
need.
need. Mm.
Okay. You have partner, Mr. Donald.
Uh, yes, yes, doctor.
You have any casual relationships? Sorry for this question.
No, doctor.
Okay. Any sharing needed? Sorry for this question again.
No, doctor. No.
Any illicit drugs?
No.
May I know your concern, Mr. Donald?
Doctor, really, I'm upset about this rash. Can you tell me what to do about it?
Yes, I appreciate your concern, Mr. Donald. First of all, maybe it's related to the drug, the medication you took from your friend. So, first thing, you have to stop this medication. It might be the reason, trigger for your rash. Second thing, we will refer you to skin doctor. He might prescribe for you some medication to control this rash, apart from the creams they prescribe for you. And if you need other, or if you have any other concern, I can address.
Um, yes, doctor. How about my hand, this hand problem? What can I do about it?
Yeah, the joint problem also associated with your condition, and yeah, your condition is called psoriasis disease, and it might be complicated with the rash, complicated or associated with the joint affection or back pain. So we have to control the original disease, which is psoriasis, and in order to control other joint and other skin rash after that. You have any other concern?
Uh, no, doctor.
So it is clear for you so far.
Yes, doctor. Thank you so much.
Okay. Back to the alcohol also. you can reduce the alcohol intake. It might be the reason. Smoking, one of the also triggers. It's a good thing you are not smoking. And the medication, as mentioned, don't take any medication without medical advice. Time is up. Okay, let's go to the examiner questions.
Can you tell me your diagnosis, please?
Yes, the top of my differential psoriasis flare
Yes.
up because uncontrolled psoriasis, either by medication or he has some triggers like beta blocker. Along with alcohol intake, it might be also the reason for the trigger.
Okay, any differential diagnosis?
Yes, I can put drug-induced rash.
Yes, that's right.
Also, I can put some infections, viral infections.
Mhm.
However, he has no any recent infection or history of infection.
Okay, how can you investigate these patients?
Yeah, starting by baseline basic investigation, blood tests, and workup, inflammatory marker, CRP, ESR for an infection. Then for the psoriasis and the association, I could do the uric acid test
Mhm.
and kidney function, liver function also to find any complication or association. For the psoriasis itself, you could do ultraviolet screening and might need skin biopsy.
Okay. How can you treat these patients?
Yeah, starting by multidisciplinary team approach, including the dermatologist and rheumatologist and orthopedic for the back and joint affection in the back, physiotherapist, social worker, and specialized nurse GP. Apart from this, counseling education about the triggers and the complication of psoriasis and the complication if he's not controlled and he's not taking the medication for psoriasis. Education about the medication can trigger his condition.
Mhm.
Then the pharmacological therapist, according to the dermatologist opinion, the first choice, the methotrexate, as a systemic medication. Also, some camouflags for the skin
Mhm.
to cover the skin rash as he is embarrassing by the look. Also, we can add vitamin D, retinoid, one of the medication for psoriasis.
Mhm.
Non-steroidal anti-inflammatory for the joint pain and associated back pain.
حضرتك قلت ايه مع الباك بين؟ سمعتش؟
Non-steroidal
على
anti-inflammatory
السرطان. اوكي تمام
analgesic.
تمام. اوكي تمام، حضرتك قلت كل حاجة يعتبر، بس يعني حاجات بس هقول عليها يعني خلاص.
Yes, sure, you can comment
اوكي
now.
طيب هي يعني زي ما حضرتك عملت كده بالظبط، هي أو speak in English sorry. So this is a patient with psoriasis. Most probably the psoriasis will come either with exacerbation of psoriasis يعني in the exam يعني, and you should exclude any triggering or trigger factors that the patient had, like any even any stress in the life can lead to flare up of psoriasis. Any new medication, even changing of jobs can lead to flare up of psoriasis. Travel history is important because one of the medications that can lead to psoriasis flare up is anti-malaria. So maybe the patient is not currently on anti-malarial, but when he traveled, he had received anti-malaria medications. And the second important thing about psoriasis is the associations. the rheumatological diseases, I mean, like rheumatoid arthritis-like or psoriatic arthropathy, I mean, in the hands. And it can come also with axial psoriatic arthropathy with the back pain. This patient actually had positive axial arthropathy, and also he had rheumatoid arthritis-like arthropathy. Also, this patient can have knee pain. knee pain can come due to it can be mechanical or inflammatory. Mechanical can be because of gout. Sometimes can come with psoriasis. Or it can be inflammatory, which is also psoriatic arthropathy. Examination of this patient will include skin examination. We have to examine everything about the patient. All of the patient we have to examine, including behind of the ears and also the hairlines. We have to examine. Also the hands. We have to do like rheumatoid arthritis examination. Everything, the effusion, the deformities. We have to do exactly like rheumatoid arthritis. Because psoriasis, some prefer with the psoriasis to also exclude other autoimmune diseases. Also, you have to cover all other autoimmune diseases. Some people would like to cover also like other autoimmune diseases with this one. And also to cover the complication of psoriasis, like to examine the chest for lung fibrosis. And also, if the patient had any urinary changes, it could be amyloidosis, of course. So you have better to examine the base of the lungs, also the lower limb edema. And this patient, we have to examine the back and to do back examination, like ankylosing spondylitis, because he has axial psoriatic arthropathy. Regarding the investigations, the one thing that you've missed, Dr. Bassam, is doing MRI over the back, but this is not his main complaint now, but we should mention it because he has axial arthropathy, so we have to also do MRI. Regarding the treatment, if the patient has only skin rash, we will go for the local treatment, like local vitamin D, the hydrogenate, and also the PUVA. Some people, if they have severe skin rash, they will give them methotrexate. Some sources say because if the patient has psoriatic axial arthropathy, it's better to start with the biological treatment directly to control both, to control the axial psoriatic arthropathy and to control the skin lesions also. That's it, I think. Yeah.
TNF, right? Infliximab.
Yes, infliximab, yes.
Okay, thank you, Dr. Sarah.
That's it.
Nice case, thank you.
Thank you, Dr. Thank you.
Yes. Any comment from differential, Dr. Sarah? Can what I mentioned is accepted as differential?
Yes, it's psoriasis, of course, but you have to exclude the skin-induced, the drug-induced rash. This is the second differential, yes, and also viral infection. I think yes, is accepted. Some people will say for the back pain, but I'm not convinced. It is psoriatic arthropathy. Some people will say, I'm not sure. I have heard about it that it could be associated ankylosing, but I think better to go with psoriatic axial arthropathy rather than associated ankylosing spondylitis.
Yeah, we had debate about that before. Which appear first, the inflammatory marker, the specific investigation for ankylosing, like human leukocytic antigen to B27. It will be with the ankylosing more.
I think both will have. I'm not sure. Both will have HLA. B27 or not. I think both of them have are considered. I'm not sure. I have to read the case. But some people will say in the MRI, if the
Yes,
symmetrical or asymmetrical.
yeah,
But
yes, yeah. Also,
يعني
the sacroiliitis as a finding specifically more with the ankylosing.
yes, that's right. But it can be with the psoriatic arthropathy also. So I think it's difficult. I'm not sure. It needs more more readings to it if it's really um يعني
Oh,
a psoriatic arthropathy alone or it's associated. I think I need to read about it more.
yeah, is it psoriatic complicated or ankylosing associated?
Yes, that's right.
Yeah, is it original psoriatic or ankylosing associated? This is the differential. I think the rash itself appearance will also give us a clue. Does the rash appear first or it was the joint first? So it,
Actually, some people,
yeah,
some sources will say psoriatic arthropathy can start even before the rash. So it's also not specific.
non-conclusive. Okay.
Another thing, sorry about this case, he is working as I supposed to ask you, but I forgot. If I need to stop because I'm embarrassed about the skin rash, but it's better to continue. He is a swimming instructor, so the water will help hydration, so it will help with the rash. So he shouldn't stop his
The
work.
concern, you mean? Also.
Yes, I forgot to bring it
But
up.
yeah, I advise him for camouflage just to cover the rash as a solution.
Yeah, that's right. Yes.
Is it related to the sun exposure? Does it worse with the sun exposure?
No, psoriasis is not. It's related more to the weather, more than the sun exposure.
No, the hydration worsen it.
Hydration. I think, because it worsens in the I'm not sure.
Hydration improve it.
Improve it, أيوة, yeah. Hydration improve it
Oh,
because it will worsen in the winter more because of the um dry skin. It will get worse.
okay. Okay. Thank you, Dr. Sarah, for the case. Any comments?
I guess also to issue as issue of safety netting non-steroidal anti-inflammatory drugs, it can trigger it if you give for painkiller. So to be safe, to be aware if psoriatic arthropathy is there, because it triggers the rash itself. What do you think, guys?
Are you sure about non-steroidal as trigger?
Yeah. Non-steroidal can trigger the rash. If it is pure arthritis, no problem. But if there is rash, we should avoid non-steroidal anti-inflammatory drugs.
So in this case, we consider the biological therapy, as Dr. Sarah said.
Okay, just for
Or
pain
first to
reliever
control,
acute,
yeah, to control the methotrexate, I think, also drug of choice.
Yeah, the methotrexate more with the peripheral joints. Yeah, the peripheral joint, we will use the DMARDs. In the axial, if the axial joint is affected, we will go directly to the biological, even with the skin rash. If skin rash alone, yes, you can go with the methotrexate alone. And then the next step, if it's really bad, not responding to the local therapy, the next step will be the methotrexate and then the biologic. But if you have a peripheral joint affection, you will go directly to the DMARDs. If you have axial joint affection, you will go directly to the biologics.
Okay.
You will skip the other steps here.
Okay. Thank you again. Thank you, Doctor.
I think we can include the differential of Kovner prototype phenomena.
Yeah. I wrote it, but I didn't mention it. Yes, you're right. This is positive and specific for psoriasis, and I should mention in the history, right? This is what you mean, right?
In the differential also, I think in the skin rash differential, you
Like what?
can like Blania, psoriasis. I think that there is another one, but what is Kovner phenomena, but I don't remember.
But lichen, it will be more or less rash, maybe confined to the hand and mucous membrane. The distribution will be against, I mean, right?
Yes, but I think here is related in the cognitive phenomena because I think the surrogate will tell you when I start it, they bleed, yeah. This is rate your I think rate is point or
We can't hear you, doctor. If you can adjust your mic, please.
I think the surrogate you said when she starts the rush, you can bleed, yeah.
Still, we can't hear you well.
Actually, this patient had positive, yeah, in the history, he has positive Kobner. He has positive Kobner. He had some skin lesion. He cut his skin with the knife, and he had psoriatic lesions over it.
Yeah, I did it in the examination and the history. Not in the examination, actually, in the history. But what my point to mention it to the examiner, right?
Yes, you should examine. Yeah, you should mention that he has positive Kobner phenomena, and this is going with psoriasis.
Okay, what other Kobner phenomena disease?
Vitiligo also has positive Kobner phenomena.
Okay.
Yes, I remember psoriasis and lichen planus, but there is third
Lichen
one I remember.
Lichen planus.
And vitiligo, lichen planus. I think this is the most common Kobner phenomena positive.
No.
Okay.
And
Any
apart
other?
from examination, chest examination for apical fibrosis, and it is important to look for aortic rigor, murmur, and collapsing pulse. At least to offer to do.
I think this finding will differentiate between both of them. The psoriasis will not cause it. I think this is the answer for the question earlier, doctor.
Yeah,
If you have
yeah.
the ankylosing features, yes, so it will go more with the ankylosing. But if no findings like this, we can say this is axial arthritis from the psoriasis, right?
In psoriatic arthritis, aortic rigor is there. In ankylosing spondylitis is there. But if it is pure psoriasis in skin, no need for that.
Again?
I mean, if there is psoriatic arthritis,
Okay.
aortic rigor examination like ankylosing spondylitis. But if it is pure psoriasis that confined to the skin, no need. No need.
Okay. No, my point is if I found the association of ankylosing, so I can suspect this is ankylosing association with the psoriasis. You got the question?
You mean the pain, the back pain?
Yes. Is it ankylosing association when I have the finding of ankylosing? The association of ankylosing. Yeah.
Okay, I get you. If you have you find this just back pain without another features of ankylosing spondylitis, this is psoriatic arthritis.
Yes, this is my point. Yes.
And differential ankylosing spondylitis.
Yes.
Okay.
Okay, I got it. Yeah. This can answer our question earlier. If this is axial arthropathy due to psoriasis or ankylosing associated with psoriasis. So the other fine.
All it is a kind of spondylosis.
Yes.
But if there is psoriatic rash, this is mean psoriatic arthritis, and a differential. The second differential is ankylosing spondylitis.
Yes, I got it.
Okay. I think it's difficult to say in the exam, in the different, it's difficult to say associated ankylosing spondylitis in the differential diagnosis because you need more investigation and MRI, and you don't have this in the examination. In the exam, you don't have this. So I think it's safest option to say psoriatic arthropathy rather than associated regarding the
Yes,
spondylitis.
yes, sure.
Yes,
The first,
exactly.
yes.
And also, Dr. Basim, in the concern of the patient, if there is something like that, you should mention not pure psoriasis, psoriatic arthropathy, psoriatic arthropathy.
Okay.
You got me? Okay.
Yes, yes. I will not say it as enclosing per se.
Yeah, yeah.
Okay. Okay, thank you. I think I clear the topic now. Any question, any adding point, any
The point
concern?
of pulmonary fibrosis with psoriasis is very uncommon to be the complication, but it's very common association with interstitial lung disease. Association, not complication.
Association with ankylosing.
With psoriasis also.
With psoriasis also?
Yes,
Psoriasis
interstitial
has
lung
a-
disease. Interstitial lung
أيوة.
disease.
It has
As
Very
a-
common, يعني the commonest than complication. In ankylosing, it's complication, not
Okay.
association. Okay.
You should
In
search for it.
psoriasis-
It's not common. It's not common with يعني it's not common with psoriasis, but you should search for it. You should search for it in the examination.
But not apical. Interstitial lung disease is the common, not apical fibrosis.
Apical.
Apical is rare.
Both are apical in psoriatic arthritis and on
Yes, but
ankylosing
it is rare with psoriasis, too complicated with apical fibrosis. But
Yes,
it
it's-
is associated with interstitial lung disease. Okay.
Yeah. And also we can correlate to the methotrexate and it will be basal. The methotrexate will be basal, right?
Yeah, good point. Yes.
Yes. The patient, if he is methotrexate, you have to check for the all complication of methotrexate.
Yes.
If the patient is on methotrexate.
Yes. Thank you for this discussion. Brainstorming, right? And I hope all got the benefit from the cases today. Any adding point, any concern, any question, any comment? Okay, thank you all. If no question, we can end the session. We'll see you tomorrow, inshallah, with the communication. Thank you. Good luck and good night. Assalamu alaikum.
عليكم السلام.